Hello, my name is Doug Mancino. I'm a partner with Seyfarth Shaw in Los Angeles, California. I'm also past president of the American Health Law Association and the co-author of the new treatise Taxation of Hospitals and Healthcare Organizations that the AHLA is supporting. And I'm here with my colleague Ruth, and she's going to introduce herself and talk about her background, both currently with KPMG as well as with the government. Ruth?
Great, thanks, Doug. Hi, I'm Ruth Madrigal. I am a principal in charge of the Washington National Tax-Exempt Organizations Group at KPMG. I previously have practiced in law firms, and I think Doug was referring specifically to the time that I spent in the Treasury's Office of Tax Policy, working on all things tax-exempt organizations and charitable contributions. So I'm really happy to be here today to talk about what's going on with exempt healthcare.
Great. Well, this podcast is really going to be conversational in nature. Both Ruth and I have collaborated on many things together over the years, and this is just one wonderful opportunity to talk about things healthcare, especially with what's going on in Congress and in the criticisms about healthcare organizations providing inadequate amounts of community benefit and compensating their executives too highly, which arguably they say deprives the community of further benefits. We're going to talk a little bit about 501R compliance. That's a front burner issue today. And then lastly, we're going to talk about the 4960 excise tax on compensation in excess of $1 million. So Ruth, why don't you lay the groundwork for what's piquing the interest at the IRS on determining 501R compliance levels as a front burner issue?
Well, yeah, Doug, I think we have not seen a lot of activity by the IRS in examinations in the last few years. I mean, obviously, the cuts in their funding over the last decade really inhibited their ability to do much exam work. But the additional funding that they've been provided has helped them to not only upgrade systems and work through a reorganization, but also to relaunch some of their exam programs. And in particular, in the EO space, they have been communicating about increased examinations. And in March, on their website, they indicated that they were especially interested in starting exams of hospitals over 501R compliance. And in that same announcement, they mentioned that they were also going to be looking at tax-exempt status and compliance with the community benefit standard. I think that's really interesting. I think 501R wise, we haven't really seen much exam activity. At least I don't think we have. There was a round of exam activity around hospitals and UBIT allocations that we saw for several years. But apart from the sort of mandatory review of every 3 years of tax-exempt hospitals that was largely done behind the scenes, and a few compliance check letters if they couldn't find a financial assistance policy, for example. We had clients that would get a financial assistance policy compliance check letter that said, hey, we can't find it. Can you tell us where it is? And then that was about the end of it. What we have heard are happening more recently are some full-blown 501R audits. And I've heard a handful have started, and I think we're going to see some more of them as people find these letters and contacts in the mail. But looking at all of the aspects of 501R, the financial assistance policy, making it widely available, publicizing it widely, and as well as the billing and collections policies and procedures that are also part of 501R 5 and 6. So I think that's a real difference and a change. I don't know. I don't have any inside information about where this interest came from, but I don't think it's coincidental that the IRS has been getting some congressional letters. For example, last August, there was a bipartisan letter that came to the IRS from some senators asking specifically about the community benefit standard and how that is reported on the Form 990 Schedule H, and sort of criticizing the IRS for lax enforcement. And then at the same time, those same senators last August sent a letter to TIGTA asking TIGTA to look into IRS enforcement. So I don't know that those are connected, but I wouldn't be surprised if they were.
Well, I have a client that's been selected for one of these examinations, and what is relatively clear is that the first information document request, IDR as we call it, is comprehensive. And I have every belief that this is a uniform, widely coordinated initiative to maximize the input of information concerning levels of 501R compliance throughout the United States. So I'd be shocked if many of the people listening to this podcast aren't already aware and in receipt of the IDR process, but it is clearly comprehensive. Several years ago, there were, as Ruth indicated, targeted 501R compliance checks. I had one concerning a psych hospital that didn't have an emergency department, as most psych hospitals do not, but it was a targeted compliance check solely for that aspect. Prior to that, we had some compliance checks that actually predated the effective date of the final 501R regulations, which made no sense to me. But now that the 501R regulations have been final for some time, I think there's every expectation that a number of footfalls will be exposed through this process. And as Ruth and I have discussed, this is really now at the level of the C-suite, because failure to comply with key elements like the community health needs assessment and implementation plan requirement not only can bring about a $50,000 excise tax, but can result in revocation of exemption, or if you have multiple facilities within a single corporation, UBIT taxation of revenues derived from a non-compliant facility. You might want to comment on that, Ruth.
Yeah, that was it was interesting when we were doing the regs for this. I happened to be at the Treasury's Office of Tax Policy when we were doing the 501R regs, and Congress really only provided a tax, an excise tax on the CH&A portion of the 501R. And so that, I think we've seen some more looking at that, and maybe a CH&A tax here and there. But the real stick sort of involved in the other pieces of 501R, the FAP and the billing and collections and type provisions, is revocation. So that's a pretty rough sanction. If there are multiple, like you said, multiple hospital facilities in one entity, and there's only compliance issues at one of those facilities, the statute and the regulations provide that you would treat that facility as though it were taxable. And so that provides a bit of an intermediate sanction in a system that has multiple facilities in that entity. But those are pretty significant sanctions. So I think one thing that probably everyone in the audience is aware of, but it's worth underscoring, is that the final regs, because these sanctions can be so big, incorporate two provisions that really provide an incentive to get at these violations first, before the IRS comes in and looks at you. One is for minor and inadvertent infractions, right? You have to have the financial assistance policy on the wall in the emergency room, and if it falls off the wall, you just have to pick it up and fix it and keep going. Minor and inadvertent foot faults, you could, if you fix it before the IRS gets there, it's sort of a no harm, no foul rule that's built in. And then there's another rule built in for more significant violations. Again, if you fix it before the IRS gets there, And if it's more than minor and inadvertent, you need to confess and correct, is how I think about that rule. You have to fix it and disclose it. But if you do that, then you're really not looking at one of those, the taxability or the revocation sanctions. So I think those are important to underline.
I'd like to emphasize the fact that this is not dissimilar from the early stages of the anti-kickback statute and the Stark self-referral law. A lot of organizations were not terribly good at complying with them, and some got pretty well sanctioned as a result. By analogy, I think this is now a provision that should rise to the compliance level at the C-suite. The general counsel should be involved. The CEO should be monitoring compliance, because ultimately the buck stops there in terms of non-compliance. And there should be a culture of compliance throughout the entire organization, going down to individual departments like billing and collection and so forth. And we do hear reports, most recently at the ABA tax section meeting, of nonprofit hospitals putting in place private label credit card arrangements to pay off hospital debt, and thinking that that might be a workaround to compliance with some of the collection requirements and collection limitations of 501R. So I would emphasize the compliance element here should be a front burner issue throughout the entire facility and multiple facilities.
Yeah, and one thing we saw when a decade ago, when these rules first went into place, was at a number of hospitals, this was a cross-functional implementation activity at the time, right? A number of folks were doing a lot of the things that were required by 501R, but we're not doing them all in one place. And maybe we're not doing them consistently. Maybe some of the community publicizing of the financial assistance policy was done in one place, and you have the billing and collections activities being done in another department. So coordination among the different activities, I think, as you said, tended to be a C-suite issue a decade ago. And I wonder about whether turnover has sort of lost some of that muscle memory in some of the organizations.
Well, I give you a recent example. I reviewed a 990 provided by a client that has a psych hospital. And lo and behold, looking at the Schedule H, they clearly did the community health needs assessment in 2021, which will be taking place again in 2024. But they reported on the Schedule H that they did their implementation plan in 2018, which should have been done in 2021. So again, that's just a minor example of inconsistent levels of compliance, even within a single organization. So multiply that if you have multiple hospitals in multiple states, and you're relying on multiple executives geographically remote from the main headquarters of the organization. That just multiplies the levels of opportunities for non-compliance.
Yeah, agreed. And all of the merger and acquisition activity that has taken place over the last few years, I think increases the level of difficulty, right, in trying to get folks all on the same compliance and making sure that you've got the right people involved.
Let me shift non-compliance gears, if I may, Ruth, to 4960, the excise tax on remuneration in excess of $1 million. And I mentioned non-compliance because the IRS publishes data about forms 4720, which are the excise tax returns filed by tax-exempt organizations, specifically with regard to identifying compliance with the 4960 excise tax. And based on data from 2019 that I got from a private source, a couple of academics wrote an article where they did what academics do. They surveyed 990s for compliance with that tax. And basically, when you compare that data to the IRS data, it indicated that there's almost 75% non-compliance with that
Wow.
excise tax. And when you
Wow.
extrapolate that to an industry that, as Ruth just mentioned, undergoes constant mergers, acquisitions, dispositions, I recently wrote in an article that this becomes a matter of financial due diligence in terms of compliance, because the onus is on the employer, not the employee, to pay the 21% excise tax if there's compensation in excess of $1 million. And the other thing I would point out is, because healthcare organizations are probably the most significant segment of the exempt organization world that do mergers, acquisitions, dispositions on a routine basis, this really should be another compliance check matter, as well as a due diligence check matter.
Absolutely. And I would chime in here, Doug. I know that you've seen it, and I think you're even writing about it, if I'm not mistaken. But this issue can hit employees even when you're not paying them more than $1 million on the regular. We've because of adjustments that need to be made, taking into account retirement plans, deferred compensation plans, and also the big hiccup, I think sometimes, is the separations, the involuntary separations that can occur, that can then trigger payment of this tax, even if you're well below $1 million in annual compensation.
Yeah, what I would say is this: if you're a freestanding nonprofit hospital, you should, as a matter of best practice, have a change in control plan. So you aren't creating a passive aggressive management that's unwilling to undergo a change in control. But that then triggers what Ruth was talking about. That is potential double trigger involuntary terminations after a change in control takes place. And so the threshold for that is considerably lower. It applies to highly compensated people, which for 2024 is $155,000. So you may have nonprofit hospitals that are maybe mid or smaller size that are going to be impacted by the excess parachute payment excise tax component of 4960.
Yeah, we frequently see clients that that they think, well, we don't really pay that many people in the system more than $1 million. We have a lot of people that are in a clump, sort of less than $1 million, and it's a big bother to try to figure out who our top 5 are. And so, as long as we're getting the tax right, and we're paying the tax on the 1 or 2 people that are over $1 million, we'll be fine, right? To which I say the answer really is wrong, because to have those covered employees, your top 5 in a given year, right, post 2017, those add up. Each year, you add your top 5 and your top 5, and people don't drop off of that. And so, even though many of them make well below $1 million and will always make well below $1 million, when you have these change in control provisions, and when you have these parachute payments that trigger the excise tax at places much lower down, and at salary levels much lower down, knowing who your covered employees are is really important. And being able to I mean, if I was the IRS, I would walk into a hospital and ask, who are your covered employees? And see if they can produce a list of their covered employees. I think a number of clients have not been investing in doing that work on an annual basis. And when you get several years down the road, it may be a much larger task to try to recreate that forensically.
Yeah, take for example, you're always going to have attrition at the senior executive level. Somebody's going to be dissatisfied or gets a new opportunity for a better position with another hospital or health system. And so the number of people today in 2024 is considerably larger than it was in 2018, the year that the provision became effective. And that's just a short 6-year span. Extrapolate that to 10 or 15 years, and you could have 30 or 40 people who are covered people. And with the fact that the $1 million threshold is not indexed for inflation, and salaries of executives are, as well as highly compensated physicians, you could be bumping against that ceiling quicker than you think. Not to mention the excess parachute payment exposure if there is a change in control.
Right, right. So should we mention a few more of the criticisms and concerns and where these things are coming from and some of the legislative activity out there?
Sure.
I can I think many people have seen that there are private study, I guess, institutes that are starting to critique hospitals and coverage of charity care in particular. And what I found interesting, I think one of the first that I saw was the Loan Institute a few years back issued a report. And it seems to me what struck me about that when it first came out was that it was using a different yardstick than I'd ever seen used in the healthcare space before, right? We've had the community benefit standard for a long time, and we've had the Schedule H, where you have some reporting on community benefit but what the Loan Institute started looking at was they defined community benefit in a different way. For example, excluding medical research and training of new doctors in the academic medical centers, which I thought was an interesting development.
Also, the legislators pick and choose data. Bernie Sanders issued a report a couple of months ago using pre-Affordable Care Act anecdotes to support his argument that nonprofit hospitals are not doing enough community benefit and are using billing practices that probably became antiquated and unlawful under 501R in 2010, but drawing from data from 2006 to make the case.
That's really interesting. So I think maybe one of the upshots of the new IRS compliance activity might, I mean, I don't know if they still will publicize data the way that they did in the college and university study that they did, 15 years ago, where they actually did a broad-based study and came to some conclusions and publicized that. But it would be useful if Congress wants to legislate in this area, and a number of these congressional letters are indicating that maybe Congress should be acting. It would be great if that was based on some new data about what is actually happening in the sector now.
Yeah, my guess is the current leadership at the exempt organization function of the IRS will be very focused on responding to congressional oversight with regard to the alleged insufficient levels of community benefit, as well as alleged non-compliance with 501R. But I think with that note, we should wrap up with talking about some of the developments that you're working on in the energy sector, because that's, I think, from my standpoint, a real sleeper in the nonprofit healthcare space, but it creates a wonderful opportunity now.
No, that's right. I've been spending a lot of time on the tax credits that were substantially modified in the Inflation Reduction Act. For years and years, there's been an investment tax credit that gave for-profit businesses an incentive to invest in clean energy investments, solar panels, geothermal, all kinds of different clean energy assets. And the Inflation Reduction Act really beefed up the credits that are available for that, anywhere from 30 to 70% is what's available now if you meet some of the requirements, the new requirements for paying a prevailing wage to your contractors, or if you use domestic materials in your construction. So 30 to 70% of the basis of that property could be returned to you in a tax credit. And the big news for tax-exempt organizations and governmental entities, so tax-exempt and governmental hospitals, we're looking at you. You are now eligible for these investment tax credits of 30 to 70%. And that's a lot of money.
They're refundable.
Yes. You don't have to offset them against UBIT or anything like that. There's a new mechanism, a new section 6417 was enacted in 2022, which makes the credit refundable for tax-exempt and governmental entities. And I think this really could change the game in terms of the financing of new energy properties. We've seen in the past that, say, for-profit engineering firms or other for-profits might come in and offer to finance a hospital's new energy property in exchange for having tax ownership, so that for-profit can depreciate the property or take the investment tax credit on that property. But now the hospital could take that investment tax credit themselves. And I think that it's important to weigh that up when you're looking at financing alternatives. And I advise you strongly to get good tax advice on this, and not necessarily from your engineering consultant, but to talk to your own advisor, because these credits are often, the people who know about these credits, the people who've been doing the investment tax credit work for years, have been doing it all in the for-profit space. So a lot of my colleagues who have been working on these credits for years have never worked with a tax-exempt client. And that's going to be true across the industry. The folks that really know the credits and really know how to do the studies that are necessary for providing the right amount of documentation, they know their stuff, but they don't know the tax-exempt space. And so it's really important to keep your tax-exempt lawyer in the mix and working on this project along with the accountants or lawyers that are doing the tax credit, because your tax-exempt lawyer will be able to flag issues for folks that don't know UBIT, for example. When you're doing these credits, if you're taking a credit and capitalizing an amount for these assets, that could have an impact on the UBIT calculations. Or there could be a variety of possible capitalization positions that are more or less tax aggressive. And having someone advising you that knows your space and knows your risk tolerance, I think a lot of times in the for-profit space, the only consideration is, how do we maximize our tax credit amount? And sometimes in the tax-exempt space, there are a range of considerations, and the rules might apply differently. And so it's good to keep your tax-exempt lawyer in the mix.
The only other point I would make, Ruth, is that unlike credits like the new markets tax credit, which you have to go through considerable hoops to make it available in terms of deriving the economic benefit at the exempt organization level, the energy credits are, I won't say they're more simple, but they're more straightforward in terms of what you have to do to claim them and get a refund.
Absolutely. Absolutely. I mean, the credits are available to tax exempts just like for profits, in that if you buy the property, if you have it installed, you have to buy it, and you have to do a cost segregation study to document your eligible basis. But then you just claim it on a 990T. That's the form that's going to be used to claim the credit. You have to pre-register. So there's an online pre-registration process. So you need to allow time between the filing of the 990T and before you file that 990T to pre-register. So there's a 3 to 4 month time period that it might take to put your information in and get some registration numbers back from the IRS. But it is a very straightforward process for getting the benefit directly, as opposed to getting the benefit through a for-profit partner.
So with that, we want to thank all of you for listening to this podcast. Thank you, Ruth, for joining me on it. And we look forward to talking again soon.
Thanks, Doug. It was great to talk to you.